rate at that instant is 80 liters per minute, you know. It only takes a fraction of a second, or, you know, to get that volume of air in. So if this is only a small, maybe half a liter, I'm just guessing what the volume might be, the rest of the air that I entrain when I go has to come from the environment, and that's not filled with anything more than 21% oxygen, okay? So I can influence it a little bit by increasing the flow rate, but the limitation with a nasal cannula is somewhere between 30 and 35%. No matter, I can turn it to 15 liters per minute, but I'm somewhat limited, again, by this. If I put a simple mask on, I can crank the flows up all the way. I can probably give somebody up to, this is what, 60% FiO2. And if I put a reservoir bag, so that now when I take a deep breath, the rest of the air comes out of this bag and not from the environment, because I've sealed everything off, I can deliver up to 100% oxygen. An endotracheal tube can do that, you know, because I am hooked to a ventilator, and the ventilator is the reservoir, and I control the inspiratory concentration of the oxygen. You know, and if you have somebody desaturating and they're on 100% oxygen on a ventilator, you've got other bad problems. You know, they're going to need to be addressed in the ICU, really, you know. But the simple application is when somebody is just sleepy on the floor, they may have some emphysema or another condition where they need some supplemental oxygen, and you want to be able to support them in the early stages so that their saturations don't, you know, their PaO2 is maybe in this 50, 60 range, and they're on the steep part of this curve, and you want to, you know, instead of having them slip down into the low 80s, be up in the 90s. And so you're going to be working primarily in this area, and you want to work in patients that don't have a lot of other physiologic limitations and issues, so that, you know, increasing their flow rate a little bit is the safety piece. It's a real simple thing. A lot of patients will start to desaturate in this range, and they just need some supplemental oxygen. And the nurse has to recognize it and come and turn them up. And what your device would do, I think, is brilliant. It would do it, and the nurse wouldn't have to. The nurse would be notified, but it would be turning it up, you know, beforehand. Is that kind of what you were thinking?
Yeah, you know, initially when I thought of this last year, and they've kind of adopted this, it was for portable oxygen use as a conserving technique.
Gotcha.
Because those little tanks don't last very long.
Right.
And there are times when you probably overuse it.
Yeah.
There are times when you underuse it. And so if you could get a feedback between the oximeter and the oxygen valve, in theory you might be able to get more life out of the tank, or a concentrator where the battery life is needed, that sort of thing. But then as they've started to think about it,
that's a completely different application.
There are a lot of different applications in the operating room, in the ICU.
Right.
In terms of reducing excessive use of oxygen or potentially reducing oxygen toxicity, which we're talking about nobody knows where the cutoff is for that, but that might be more pertinent to your needs.
Yeah, that's a great idea.
So I think potentially there's a lot of applications.
And they are very different kinds of applications, and all important for different reasons. But you have the feedback loop in there. Like for what Dr. Howard was suggesting was, in neonates, they want to, especially as a very vulnerable population, where the oxygen, you know, causes, gets broken down, there are free radicals that are generated, and they injure the infant, because the infant can't scavenge the free radicals. It's something that you don't even know your body does, and it does this for you. So they would want to keep the saturation. They wouldn't want this PaO2 to ever be up in this range out here, because there would be more of these free radicals. And they feel it's much safer if the baby lives with a saturation that's in this 90 range, which the infant is going to have a PaO2 somewhere, you know, 50 or so, you know. And that's kind of where they want the baby to live, so there's not a lot of additional oxygen causing, you know, free radicals that will injure the infant out here that the infant can't handle. Just enough oxygen to meet the metabolic demands of the infant.
And then in terms of just battery life and stuff, you see that population. We don't work with that population specifically, and that's another brilliant application because there are expenses involved with that, and this could save like you said, batteries, oxygen tanks, and those things are all very expensive. For us, that's never a limitation. There's a lot of oxygen in the hospital, and oxygen is relatively inexpensive in a hospital setting compared to a lot of the other fixed expenses. What other questions do you have?
I got the questions.
What about
The questions. I have it under here.
What's that?
I don't think he wants to be on the recording.
I don't.
You can just pause it.
It sounds weird when I'm in the recording.
Alex, you can just ask it.
I know, but it sounds really weird.
which one do you want to ask?
No, just keep looking through them. I think I added one. I have to make sure I'm still on him.
Alex, just go.
No, just. I think I added one yesterday.
Yeah, we've
Okay.
asked all those basically.
I'm not sure yet.
So when we're like developing our program, equation, whatever we're making, what factors would be important to incorporate for your application specifically?
So, software programming isn't really my field. But
Yeah.
so when you're saying that, basically, I just want to know when their saturation drops, and kind of what their flow rate is, and whether or not I can increase the flow rate significantly to influence this PaO2. And so you're influencing in this range, and you're going from anywhere from like room air, which is 21% oxygen, to to like what do you run people on at home?
2 to 6 liters.
To 6 liters to
International arbiter per second.
Yeah. So in terms of developing a program, what factors? Definitely want to know their SAT, right? And have that be the primary trigger for the feedback loop. You're going to have to know whether or not the trace, in a sense, like, you're turning up the oxygen, but now the probe is off somebody. And the probe, the thing about a lot of these oxygen saturation probes is the technology that's involved, there's an infrared light and there's 2 wavelengths, and it shines through, and the receptor, then goes through this algorithm and determines how much oxyhemoglobin is present compared to how much deoxyhemoglobin is present, based on the absorption of those 2 wavelengths of infrared light. Okay, you know this one. So when the probe is off, the default is in the mid-80s, which would look like you would want to increase the flow of oxygen. And so, but that would then, you'd be increasing the flow to a maximum concentration and run the battery down, run the tank dry, when the person's probe is partially detached. So you have to actually kind of build into it, right? I assume, you guys don't use a waveform, you just use a number. But we actually look at the characteristics of the waveform. So every time there's a heartbeat, it goes, on the EKG tracing, it goes boop, boop, boop. Here,
Yeah, you
I have
can
a
just
I'll use your piece of paper. So there's a little, heartbeat, boom, looks like that, right? Then right behind that is this, on the oximeter, is a little pulse that goes like that, And so this is the pulse of blood, and the oximeter is going to measure the percent SAT. And it's going to give you a number, but if the waveform looked like this, or, or wasn't, it was all over the place, I wouldn't feel that I could interpret that number accurately. I want to make sure that, for every EKG trace, this little pulse of blood going through the finger is demonstrated, and now I can look at the number and be assured, or be better assured that that's going to be more reliable. And again, you look at the patient, and